Thank you for the kind introduction, Dr. Carter. And I want to thank and shout out to Mr. Farrington for the invitation to, and honor for the invitation to speak and be a participant at this wonderful summit to inform patients and policymakers and potentially caregivers. Just a word about the U.S. Preventive Services Task Force. We are a national independent group of volunteers with experience and expertise in primary care, disease prevention, and evidence-based medicine. Our mission and our work is to help everyone in this nation live longer and healthier lives. And you're going to hear some very common themes from the prior three talks. And with that, I'm going to share my screen. So this is our most recent 2018 screening for prostate cancer recommendation.
Dr. Wong, we don't see your screen as of yet.
Oh, okay. Let me say share.
Okay.
And do you see my screen now?
Yes, perfect.
Thank you. So this is our most recent 2018 recommendation. For men age 55 to 69 years, the decision to undergo periodic PSA-based screening for prostate cancer should be an individual one and should include discussion of the potential benefits and harms of screening with their clinician. Clinicians should not screen men who do not express a preference for screening. This is a C recommendation for us, which you can think of as a choice. We also said that the task force recommends against PSA-based screening for prostate cancer in men 70 years and older. This was a D recommendation, D as in don't. So our recommendation also goes on to say patients and clinicians should consider the balance of benefits and harms on the basis of family history, race, ethnicity, comorbid medical conditions, patient values about the benefits and harms of screening, and treatment-specific outcomes and other health needs. So what do we mean about the balance of benefits and harms, and what do we mean about shared decision-making? Well, in 2018, in 1,000 men aged 55 to 69 who were offered PSA screening, based on the European PSA screening trial, we found that out of those 1,000 men, 3 would avoid having metastatic cancer. And as you've heard, 1 of the 1,000 would be saved from dying from prostate cancer. On the other hand, there are 5 other individuals who die from prostate cancer despite treatment or surgery. Now, what are the potential harms? And you've already heard a bit about this. One is false positives, meaning that the PSA is elevated, but it's not from prostate cancer. It could be from benign enlargement of the prostate or an infection or other causes. But that false positive leads to additional tests, including biopsies, which can cause some harm, including pain, infection, or bleeding. And as you've heard already from Dr. Barakas, that can lead to something called overdiagnosis, meaning that it's a screen-detected prostate cancer that in some men would never become symptomatic and never cause them to die from prostate cancer, and as a consequence lead to overtreatment and the potential harms from treatment. And those harms from treatment can include erectile dysfunction or urinary incontinence. So some other considerations regarding benefits. When you think about treatment benefits, they can occur at any time, but generally they are years later. And why is that? Well, because progression from an asymptomatic screen-detected prostate cancer to the development of symptomatic cancers may take years or even decades, or as an overdiagnosis, they may never become symptomatic. And what about the timing of the harms? Well, the possible harms could potentially occur very shortly or soon after a screening test, after diagnostic procedures such as biopsy, or even treatment with surgery or radiation therapy. On the other hand, as you heard, active surveillance with monitoring those low-risk prostate cancers, what are called Gleason 6s, have been increasingly used to decrease the harms of treatment, as mentioned by Dr. Barakas. So the U.S. Preventive Services Task Force developed this infographic to answer the question, is prostate cancer screening right for you? And the idea here is to inform men about the potential benefits versus the risks for men 55 to 69. And on the top, you see 1,000 men offered PSA-based screening who are 55 to 69. Out of those 1,000, 240 will get a positive result, which could indicate prostate cancer. Out of the 240, 100 of them will get a positive biopsy showing definite cancer. That is, they see cancer cells when they take a piece of the prostate out. 80 of those individuals then will choose surgery or radiation therapy. 65 of them will have those treatments right away. Another 15 will undergo that active surveillance of low-risk prostate cancer, but then that low-risk one progresses and they undergo surgery or radiation therapy. Among those 80, 3 on the bottom left will avoid cancer spreading to other organs, what we call metastatic disease, and 1 will avoid death from prostate cancer, but there will be 5 others who die from prostate cancer even after surgery or treatment. Now I want to turn your attention to the right-hand portion of this graph where you see the 20 to 50%. That means that 20 to 50%, these are our best estimates, out of the 100 who get a positive biopsy may have cancer that never grows, spreads, or harms them. And these are the individuals who are felt to be overdiagnosed and potentially overtreated. Now, among the 80 men who choose surgery or radiation therapy, 50 of them may develop erectile dysfunction, and 15 of them may develop urinary incontinence. Those numbers come from 3 trials done in men, well published in highly cited medical journals. So what that means for me is this C recommendation implies there's a choice. And for me, this makes whether or not to get a PSA screening test in men 55 to 69 as a preference-sensitive decision, meaning that there are benefits, but there are also harms. And so what's important when you think about preference-sensitive decision-making is that they rely heavily on individualized values that they place on the benefits and the harms. So for example, an individual who really wants to reduce their chances of having metastatic disease and dying from prostate cancer and is willing to accept possible harm, including overtreatment, well, for them, screening is the right thing to do. On the other hand, for no screening, if a person is willing to accept an increased risk for metastatic disease and dying from prostate cancer, and they really want to decrease any possible harm, including overtreatment, then no screening may be right for them. The way I talk about this in my practice, in my primary care practice, is I have some patients who prefer prostate cancer screening, and I have other patients who prefer not to be screened for prostate cancer. if you're someone who knows what it's like to die from metastatic disease or die from cancer, and you really want me to do everything I can to reduce your risk of having metastatic disease or dying from cancer, regardless of any potential adverse effects, then screening is right for you. On the other hand, if you're the kind of person who says, doc, I'm feeling pretty good right now, I don't want you to go look for trouble, and I'm just as happy where I am without causing any potential harms. Well, then perhaps for you, no screening is right. Now, we have a specific section in 2018 regarding screening for prostate cancer in African American men. So the task force recognized that Black men have an increased likelihood of developing prostate cancer and an increased lifetime risk of dying from prostate cancer. And as you heard before, either a 2- or 3-fold increased risk versus white men. But we also found, as you heard, very little available trial evidence, mainly the few individuals in the PLCO study about the benefits or harms of screening in Black men. There is a bit of evidence that there are more major infections after prostate biopsy in Black men. But as a consequence of that lack of trial evidence, the task force was unable to make a separate recommendation. However, we acknowledged and recognized the increased risk in Black men, and we were aware that there were computer simulations suggesting increased benefit of screening and possibly screening at younger ages. So we found it to be reasonable and recommended that healthcare professionals should inform their Black male patients about their increased risk of developing and dying from prostate cancer and the potential benefits and harms of screening. And this is what I want to emphasize, so they can make an informed personal decision about whether to be screened. Now, that's where we sat with the evidence in 2018. A part and key part of our recommendations, which end up going to Congress as areas where we need more research, is the following slide. The USPSTF strongly encourages research on screening for and treatment of prostate cancer in Black men. We need to confirm that screening Black men decreases prostate cancer mortality, and we'd like to know more about the optimal screening frequency and the age to start screening. We need strategies to decrease the harms and increase the benefits of screening, diagnostic follow-up, and treatment, including active surveillance in Black men. And I'd like to close with, it is also important that research and quality improvement activities continue to work to eliminate disparities in access to high-quality care for men with prostate cancer. I thank you all for joining this summit and your attention, and I will stop sharing at this point.